and go over all of the things that he's been busy with, and I'm sure that you all have a full plate. So we really appreciate the time that you give us by joining us for these regional nurse updates. So I just wanted to, I'll share my screen really quick and go over our meeting today. Dr. Elizabeth Walker was, can you see the agenda? Okay, so as you can see, we have, oh my goodness, I am so sorry. I completely removed Garth from the, I don't know how I did that. I'm sorry, Garth. So from 9 to 9:30, I apologize. I'm gonna go ahead and go in there and change that. But from 9 to 9:30, we have Garth Donald from the Chelan Douglas Health District. And let me fix this and we'll get back to you. We have Garth from the Chelan Douglas Health District is going to be talking to us about the opioid trends that he's seeing in the state and nationally, but also in our own area. Garth has been working with the Chelan Douglas Health District for, has it been a year and a half now, Garth, or 1 year? Okay. And so he has been in a position to really get a good understanding of what we're dealing with here in our region as far as the opioid epidemic. And then we will have, so I'm just fixing this and getting it updated for us, for you. I apologize about that. And then we will have our regional and state updates from Kathy. Let me try sharing this one more time. Sorry about that. Share. Okay, this should be a bit better. So as you can see, we'll hear from Garth, and then we'll have our state and regional updates from Kathy. And then we will hear from Dr. Wallace when he comes on at 10. Dr. Walker, we were going to be hearing from her today about our the wildfire smoke and forecast and air quality. She is sick today, and Oscar Benavente has very graciously and kindly agreed to join us to go over Valtoco. He was at this conference, and I can tell you a little bit more about meeting him when we get moving with when he's on the meeting. So as always, our meeting objective, or our update objective for these gatherings every month, are to get updated information on state and regional happenings and occurrences that are affecting our practice, to learn about resources and practice opportunities that will help us help our students. And then hopefully you can come away from these with 2 new resources or practices or opportunities that you can utilize in supporting your students. As a reminder, this is recorded so that people can log back into the meetings and watch them later. But also, we don't want that to be a deterrent from you asking questions. So please feel free to raise your hand if you have a question, or put something in the chat, as Sheila and I will be monitoring the chat and can voice your questions for you if you'd like. There's also some information on there about receiving clock hours if you'd like to for this meeting. Oh, and that's for the end. So I'm going to stop sharing. All right. So Garth, I'm going to go ahead and turn the time over to you. Again, we're grateful that you're with us, and we also wanted to just hear from you and what's going on with the opioids in our area.
Absolutely. So again, my name is Garth Donald. I'm the Behavioral Health and Substance Use Coordinator for Chelan Douglas Health District. So today We're going to be talking about where we are nationally and regionally with the opioid crisis, as well as where we're at with the rollout of publicly available naloxone. Do you happen to have those slides ready to pull up? Awesome. So, well, we're getting that ready. The biggest news on a national level, and you may have seen this. We're still, the 2024 numbers are still a little preliminary, but it does look like we've been successful at turning things around. So we have been increasing overdose deaths nationally every single year for heck, a couple decades at this point. 2024 seems to be a decrease in fatal overdoses, which is great news at face value. And so, yeah, perfect. So here's a slide here. And this data is at this point a year out of date, but you can already see the chart on the left is our drug overdose deaths in United States, and you can see that it seems to be slowing down. And again, that graph is a year old. At this point, it is definitely on its way down, slowly but surely. But my big warning, like that's really good news at face value. But my big warning is that I don't think overdose deaths is the best way to measure where we are with the opioid crisis. To me, it's more important that we have numbers on how many folks are using, and that's just really difficult data to capture. Stuff like overdose deaths or overdose hospitalizations are much more straightforward because it's a fairly automated reporting system. So there can be a lot of things going on. Absolutely, nationwide, we're doing a really good job of trying to raise awareness about opioid addiction and really trying to beef up our treatment options. And we're doing that locally as well. But at the end of the day, you've heard about naloxone, it's publicly available, and we're getting much better at reversing overdoses in the field. And so there might be a little bit of that's going into why the overdose deaths are going down. And a couple other factors that are not very fun. At the end of the day, overdose deaths going down. I'm not putting all my eggs into that data basket, though. But at the very least, that's at least one positive sign we do have to work with. The map that we have over on the right is an indicator of the changes in overdose death rate per state. And so you will see over on the West Coast, everything in the darker red you get, the more of an increase in overdose deaths were seen. And so this would have been for August to August of 22 to 23. Anything, the darker blue that you have, the larger of a decrease in overdose deaths. So last year for the cycle, we did see the Pacific Northwest was definitely having an increase in overdose deaths, but I do want to stress this is only tracking the change in the rate, not in the overall total deaths. West Coast, so far in the opioid crisis, the West Coast has always been a couple years behind the East Coast. So this isn't a really surprising number to see, but it is important. We're going through a pretty major shift in our part of the country. So it is still problematic. We still have an issue that we're struggling with as a community. All righty, next slide. All right, so just to put into perspective how serious the issue is, specifically with fentanyl, this chart tracks deaths related to fentanyl, heroin, or prescription opioids. And so prescription opioids are going to be the pink line, and you'll see in 2021 is when we really started cracking down on kind of loose prescriptions, if you will. And the purple line is heroin. That's basically dropped off the map. That drug is no longer in vogue, you may say. The yellow line is our synthetic opioid, specifically fentanyl is the beast that we're tracking with that. And so when we talk about the opioid crisis, we're definitely now in a phase where it's really the fentanyl crisis. We still say opioid crisis because there's specific treatments that are universal to any opioid of any type. And you know, who knows, fentanyl might disappear the same way that heroin did, and something else may take over. So at the very heart of the matter, fentanyl is the problem, but it's still, in general, we're treating it as an opioid problem overall because that's the treatment options that we currently have available. All righty, next slide. All right, so this is the kind of medical system burden in the region. So this is the North Central Washington region. These are the numbers for what we saw in the full 2022 annual cycle. And this is kind of the most recent data that we have to work with. It takes a while to crunch through this. But you will see as far as what we're looking at for hospitalizations as well as emergency room visits, between 3 to 5% of our medical system load in emergency situations is related to opioids. However, close to a third of all of our injury deaths in the region were from opioids. So as far as the impact on the hospitals themselves, it's substantial enough we're paying attention to it, but this is a serious enough issue that you can see a lot of folks are simply not making it to the hospital, or they're not making it into the EMS cars. So still very, very serious. We're seeing it in the hospital, and we're definitely working to target hospitals as a point of entry for folks to get into opioid treatment. And that involves getting recovery coaches, folks who've lived through addiction and are helping folks get out of that cycle. We've got recovery coaches available in the hospitals, and we are working to get some kind of a standardized set of medications that are specific to treating opioids available in the hospital. So it's definitely something we're targeting right now because it's pretty clear that that's a very good way to capture people when they're pretty deep in the opioid addiction cycle. All right, next slide. Cool. So when it comes down to numbers, I was told you guys love numbers and statistics. So I track the monthly overdoses in the region. And so this is from May of 23 up until most recent that I have is August. And just looking at it, you'll see that it appears to have a slight downward curve. My big warning with this one is these numbers are low, and we're talking between 15 to 30. When the numbers are this low, it's very, very difficult for us to realistically track what direction we're really going in. And so even when you're looking at a statewide versus a national count, the smaller your numbers get, the less reliable the trajectory is. So at face value, looks like we're starting to do better in our region, but I do want to stress there's really not enough data. So if someone comes to you and says, hey, in this, in Wenatchee or in this region, we're doing really, really good, or we're doing really, really bad, it is totally okay for you to pump the brakes and just say, we really don't have enough numbers out here. There's not enough people for us to be making this call. This really is something we need to look at a state or a national level to see, to be able to plan for what the next few years are. So I did want to show you guys this. I did want you to kind of see realistically what the numbers are looking like in our region, and just want to say take all of this with a grain of salt because our numbers are realistically very low around here overall. They're very serious, but they are fairly low. All righty, next slide. All right, so naloxone, I'm sure you're all aware at this point, all schools in Washington State need to have naloxone on hand. Naloxone is an opioid antagonist. It's an opioid blocker. So if somebody gets opioids in their system, taking fentanyl, accidentally taking fentanyl, or that maybe they took prescription opioid pills, whatever the case may be, if they happen to go into an opioid-based overdose, naloxone will, or it will reverse the overdose. Naloxone sits in the opioid receptors in the brain and will stop an overdose from happening for about 60 to 80 minutes is the effective range of naloxone. Naloxone is the medication. Narcan is the most common brand of it. A lot of people use the names interchangeably. There's nothing wrong with calling it Narcan. I just call it naloxone because I figure someday some other brand is going to overtake Narcan, and to limit confusion, naloxone is what I think is a good universal name. You should have this at your schools. You should have a few folks who are trained specifically on how to use it. It's not super complicated. In the next few slides, we're going to go over it. I will say when it comes down to where you're storing these at your school or really anywhere, I think a great place to have them kept is with your AED devices or in your first aid kits. That way, everyone on staff knows that when there's an emergency, this is the centralized location to get these emergency services. All righty, next slide. Cool. So the Narcan that we see here is an intranasal spray. It's just a nose spray. It's a 4 milligram dosage. It's very easy to administer. There's minimal side effects. So it's an opioid blocker. If you don't have opioids in your system, it's really not going to do anything to you. So if you find someone who you suspect is having an opioid overdose, but you're not quite sure, there's a million different reasons that people become unconscious or pass out. If you're in doubt, but there might be a case that it is an overdose, naloxone will be safe to use on someone, even if they're not having an overdose. It is safe to use on anyone of any age. It can be used on children. It can be used on pets. It's a fairly innocuous medication if there's no opioids in the system. Just so you know, there is an injectable naloxone available. It's very uncommon. It used to be the primary delivery method. So if that's what you've seen or heard of in the past, you're not wrong. That's what we used to do. But these days, there's just been a huge rollout of this nasal spray. It's much easier for the layperson to use. I definitely prefer it. So nasal spray is what you're going to be seeing 99% of the time when you come across naloxone. All righty, next slide. Cool. So when it comes down to naloxone administration, first of all, when you run across someone that you suspect may be in an overdose, check on them. When someone is going through an opioid overdose, they'll have very slow or repressed breathing. They might be gurgling or gasping, cool, clammy skin, blue lips, or perhaps under the fingernail beds starts to turn kind of blue. Opioids will depress respiration. They're not breathing so much. So even before you go into an overdose, you'll start seeing signs that these folks aren't getting enough oxygen. There might be needles or pipes or pill bottles around them as well. First thing you do in all cases when you run across someone who is not responsive, you call 911. That is going to be your first step every time. Let 911 know they're not breathing. Let them know you may suspect that there's an opioid overdose. They're going to walk you through the next steps, but the next step is going to be getting naloxone into this person. So follow the instructions on the packaging, but at the end of the day, it's just a nose spray, one nostril, one dose. Just press the button once. It's all going to spray up into their nostril, and that is a single dose of naloxone. 911 is really going to walk you through what to do after that, but the Department of Health recommends that at this point you begin rescue breathing. Again, opioids will stop someone from breathing, so that's going to be the first step to keeping them alive. Naloxone takes about 2 to 5 minutes to become effective, so the manufacturer recommends if the person does not respond in 2 to 5 minutes, give a second dose of naloxone. Keep in mind during an emergency when someone's not breathing, it's very hard to wait for a full 2 minutes. You can't go wrong by giving a second dose of naloxone. So many people will, and I won't judge you for it. I am starting to hear reports from the field of folks who are loading up on 10 or 15 or even 20 doses of naloxone. That's extraneous. That's someone who was panicking and just had a ton of naloxone around. 1 dose is going to be enough in 99% of the cases. 2 doses, definitely. If someone needs more than 2 doses of naloxone, they took a absurd amount of opiates. Pretty unlikely you'll need more than 2. And so boxes of naloxone are packed in 2 doses of 4 milligrams. That's almost certainly going to be enough. It's a very rare circumstance that you would need more than 2 doses. And at that point, continue rescue breathing. And again, keep 911 on the horn. They're going to walk you through everything. All right, next slide. So that's naloxone. I know you guys have had trainings on it. If you haven't had a training on it and you want one for your school or you want one for your staff or even for your students, feel free to reach out to me, Garth, at Chelan Douglas Health District. I am happy to come out and give a much more full training on naloxone and opioids in general. So that is always open to you guys. I'm happy to come to you. Just let us know, and I'll bring my kid out and give about an hour presentation on it. But I did want to touch on one other thing that's been bothering me a lot. I do a lot of work with substance use in general. And I just saw this one's rolled out rather recently. We're going to switch over and talk about vaping real quick. As you guys know, vaping is becoming problematic for society in general, but specifically for our youth. It's very, very clear that a lot of the vape manufacturers are specifically targeting youth and getting an extremely addictive substance into kids when their brains are really not ready for it. And unfortunately, there are some manufacturers who are going to pretty far lengths to make this a kid-friendly way to consume nicotine. So the first one is Smile Labs has released, and I've seen these, they're on the streets, I've seen them. They are pens that have a vaping device built into them. You'll see it looks just like a pen. It even has ink in it. You can write with these things. They're very convincing. It's clearly designed to hide a vaping device. That's what they're for. They're called Smile Labs, and I'm definitely not smiling about this one. So I just want to let you guys know this is on the market, and it doesn't look like a vape pen at all. And it definitely is. This same company makes, and this is the one over on the right, and this one really, really has me upset. This is a Pokemon ball vape device. This is insane. This is clearly made for children. Wildly inappropriate. The manufacturer of these products has definitely crossed a very serious line. I just want to, I know you guys know, but I want to make this one completely obvious. They are clearly targeting children. They have candy flavored vape cartridges loaded with nicotine. They're selling devices that, I mean, this is for preteens. This is the demographic they're shooting for. This is just, it makes me furious. And I want to make sure you guys are aware that this is what kids are dealing with. And it's being openly advertised to them and pretty readily available to them. Let's hit that next slide just to show you where we're going with advertising. So this is for the company that makes those Pokemon vape pens, these are the influencers that they pay, and you'll see that They specifically have 1 million followers on YouTube or 2 million followers on TikTok. This is the media that our youth are consuming, and there's really no legal limits on what these folks are promoting or what they're pushing. And yeah, so on TikTok, there are famous people who are openly saying, we endorse candy flavored Pokemon vape products. Like, this is really, really nuts. So I'm trying to just raise awareness and let folks know that we're up against something very serious, it's just a behemoth. We've never had to deal with anything this big and this uncontrolled before. And then here's the little the workaround of the company. I pulled this right from their website. In their FAQ section, is this a tobacco product? No. This is a writing pen. It's intended for aromatherapy. There's no tobacco extract or anything in it. It's an aromatherapy. This is clearly nonsense, and they're using this as a legal workaround. This problem is going to continue to grow, and just bringing this information out there. I'm not advocating anything specific at this point, but just so you can kind of know some of these solutions that other countries are coming up with. This July, just previously, Australia as a nation outlawed vape products and vape pens. And then in October, as kind of a supplement to the law, they made nicotine vape pens only available from a pharmacy. You have to be over 18, and either, for depending on the circumstances, you have to have a prescription to be able to get these, in order to, so the doctor is helping you deal with nicotine addiction. You either need a prescription or you need to have a pretty specific conversation with pharmacy staff. There are countries who are putting limits on vape pens. It can be done, and it is being done. So I just want to throw it out there. I'm not advocating anything specifically right now, but if you happen to hear of folks who are pushing for legislation that would limit access to vape products or limit vape products in general, I just want you to know it has already worked in other countries. It is possible. This is not a fruitless battle. It can be done. It is being done. And hopefully this nonsense you see here is the proof that we need to start making serious steps to limiting this. So yeah, sorry, that one's a bit of a bummer, but did just want to bring that one to everyone's attention. So yeah, that kind of wraps up what I have. Again, I really do want to let you guys know I am available to come out to your schools, talk to your staff, talk to your students about opioids, about naloxone use. And we also just hired on a really fantastic health educator who would be available to come out to schools and talk about vaping, nicotine, other substance issues like that with your students. This is something I take very, very seriously, and I think we need to work together, because boy, are we up against a billion-dollar industry at this point. So anything we can do to help, I am more than happy to. Just reach out and we will come to you. Cool, that's all I got.
Thank you so much. It's kind of scary to see some of the things and the ways that our the industry is disguising some of those products for students to consume and try to sneak past people. It's alarming.
And oh, sorry.
Go ahead, Kathy. Yeah.
Well, I just wanted to add, well, we really appreciate you coming out and being able to provide health education in the schools, and to know that you have a new health educator. And just as a quick reminder also to folks, we do have programs through Grant County Public Health. So if you're in Grant County and you want to connect with the Grant County Public Health District, you can go to their prevention and awareness page, and that's where you could actually order Narcan if you needed visits and or request Narcan training on that website. They also have health educators who specialize in naloxone training. And then Okanagan County Health District, you could go to their harm reduction program website. And we also have an additional opioid reduction program in Okanagan County that you can access as well. And they're more than happy to come into schools and provide additional training for your staff and yourself. And just as also a reminder, Okanagan County has the syringe exchange program as well. So just more additions, more resources for you to tap into.
Thank you again, Garth. We really appreciate you being with us and all your hard work on this issue for our area. So if anyone has any questions for Garth, he put his Amber put information for Grant County Harm Reduction Coordinator. I have Garth's contact information. We can help get you connected with him. He just put his email address in the chat for us too. So if you have any questions, please reach out to these folks. I'm sure they'd be happy to help you with getting the word out to your staff as well. So thank you again for being here with us. And Amber and oh shoot, I lost your name, Alexis. Thank you for being with us as well. So it is 9:30 and I'm going to turn the time over to Kathy for our state and regional nursing update.
Okay, thank you, Lena, and thank you everybody for being here today. I really appreciate you, and I'm going to go through some updates before Dr. Wallace gets on. So let me make sure that okay, can you see my screen, Lena? Okay, is it in slide mode? Very good. Okay, so happy October. Boy, Halloween's going to be here before we know it. So we got to be ready for that as well. So let's go through some quick updates here. I have them organized kind of by agency. So first of all, my first update is I just wanted to thank everybody who was involved in some way with the School Nurse Organization of Washington's conference. We just had our conference on Friday and Saturday this last week, and we had about 130 people register for the event. So lots of great presenters. We had several local presenters, including Dr. Brezhny and Shelley Hansen from Ephrata School District. I wanted to thank our best mentors and mentees. You can see them in the photo here for their participation at this event, and all the people that were involved in this were just stellar. So many, many good presentations, and looking forward to the next snow event, which will be coming in March of next year. So more things to look forward to. Quick update from our department on where we're at with the school-based telehealth project. So this is just a list of the districts that we now have a school-based telehealth access point set up for, and they are in different stages here of implementation. So some of these districts have had their TAP site set up since 2023, and others are getting set up as we speak and have their training lined up with the Ingenium folks so that their staff can learn how to schedule and set up telehealth visits for their students. And we're working with a variety of clinical partners. So for the big ones, because we started with behavioral health, we've been working with groups like Akin, Catholic Charities, Renew, and the Center for Alcohol and Drug Treatment to make sure that we're providing some behavioral health services for students. And we have several of these school districts now who have set up telehealth visits with their providers. So we are trying to keep this local and connecting students with local resources to help them, as well as their families. We're also in discussion right now with a variety of groups who provide services to our students, including Seattle Children's, Providence in Spokane, Three Rivers Hospital is very interested in looking at telehealth services. And I know Casey's on the line from Mansfield. She'll be having some conversations with them, as well as with our Ingenium team this afternoon, as well as Soap Lake and Wilson Creek. So we're in the process right now of touching base with several of the schools to see how they're doing, what they need help with, and to kind of branch out and provide additional services, particularly for those students who have chronic conditions and they may not get to see their provider more than once a year. Seattle Children's is a good example of that, as well as Providence and Spokane, where the kids don't get to see their providers very much. And we're not trying to reduce those in-person visits. We're just trying to supplement them with access to their provider via telehealth. Currently, we have several kids who come down to Wenatchee to see their provider via telehealth. So they're coming to the clinic to connect with their provider in Seattle via telehealth, but they're still having to drive to Wenatchee to do that. And we're trying to reduce those kinds of visits where they could remain in school and be able to connect with their provider remotely, so from their school district. So that's where we're at with that. We have one additional set that we're just in conversations with school districts right now about setting up. And we have a couple of grants kind of in the pipeline to get more funding for this program to be able to branch out even more. So that's where we're at with that. Naloxone in schools, I'm so glad that Garth was here providing some updates on that. So just some quick reminders on the naloxone in schools project. This has been running now for like 4 years, I think, 3-4 years. We still have quite a bit of naloxone in-house. So if you are in need of naloxone, please ask and we will get it to you, because we have a plentiful supply. We're kind of in the process right now of removing some of the naloxone for the districts that's due to expire shortly and replacing it with other doses. So if you have a need, let us know. Those of you who are working in tribal schools, Ben, I don't know if you have an interest in this, but there is a project that is going to be looking at opioid education in the schools for tribal schools. And they're going to be piloting some content and coming up with some curriculum this school year. So this is a 24-25 project. And then once they kind of get the bugs worked out of that, they're going to be launching a statewide program specifically for tribal students. Those of you who would like more training on fentanyl, we offer a monthly class. It's called Fentanyl Fast Facts and First Aid. And there are courses every month that you could complete via Zoom. These are live instructor courses, so you need to pre-register for them. The next course is coming up October 29th, and all of these are in the calendar. So you can go from month to month and you'll find Fentanyl Fast Facts. These courses are 1 hour, and most of them are from about 12 to 1, but they vary somewhat. So you can find those courses in there. And then a couple of toolkits I just wanted to remind you about. Sometimes we get questions about where can I find resources to do this work. NASN has an naloxone education toolkit, and you can kind of see up in the right-hand corner, those are some of the elements of their toolkit. The SAMHSA Youth Substance Use Prevention Month toolkit, because October is Youth Substance Use Prevention Month. So they have a toolkit they've put out, but there are tools in there you could use anytime. So it's not really just specific to the month of October, but a couple of toolkits that you can access for that information. So let's do some OSPI updates. Okay, so things to watch for. These are just things to be aware of because of changes in perhaps the RCWs or WACs. So new laws have come down, new standards and new guidelines. And so those are going to create policy changes. So we'll keep you on top of these things. We'll let you know if there's a change to the policy or the procedure, but just know to expect that there's going to be updates this year to the anaphylaxis policy and procedure, diabetes, infection control, and opioid response. And so revisions not only to the model policies, but to some of the guidelines that are in existence as well, because we need to keep up with current practice. And so as those things are launched, we'll let you know, so you don't have to go out and hunt them down. But those are probably the 4 that you're going to see changes in this school year. Neffy is now available. So for those of you who are looking for another option and an alternative to injectable epi, then Neffy is an option if you have orders for that, or if you use your standing orders to bring in Neffy, then you're going to have nasal administration product available for epi. So if you have any questions about Neffy, you can link right to their website there, and there's training videos that you can use and refer to yourself, as well as a variety of other information, both for healthcare providers as well as for the general public. So for your students as well. I know we brushed on the Washington Poison Center series. I mentioned it at our update last month, but it's just a reminder. It's just an excellent program. It has so many individual recorded sessions that are all posted and available to you now, and of course, they focus also on drugs and naloxone and fentanyl and a variety of other factors, but there are many there. And so I would encourage you to take a look at the series. You can watch the recordings, and all of the PowerPoints that are presented are available on this link as well. So just an option for you. The Washington DOH School Nurse Connects, those have also been scheduled, and you'll find them in the Google School Nurse Calendar, so you can look ahead. There's only 3 for the school year, so the next one isn't coming up for a while. We just did one like 2 weeks ago, and we had Will Hitchcock come in from Washington DOH and go over the current, or the most current, reported information on concussions in the school districts, and talk about the reporting mechanism and concerns around concussions. So I'm not sure what will be on the next School Nurse Connects, but we do encourage people to look ahead and register for those events, because it's a great opportunity to connect with experts at the Department of Health to go over a variety of health-related concerns. And then finally, I just wanted to let you know that OSPI, through legislative decisions, are going to be offering AEDs. And so they're going to be offering some grants. And so if your district is in need of an AED, we'll send this information out as soon as we have it. It will be sometime during this school year that there will be an application process, and you could apply for some fundings to help support the purchase of another AED for your district. So be watching for that, and just know that is coming. Wanted to make sure you were aware of this new guide. This has just come out, and OSPI has encouraged us to take a look at this. This is on the anonymized threat response guidance, a toolkit for K-12 schools. And this particular tool is really intended for, what do you do when you have call-in threats? You know, you have a call-in, you have email or text coming in, you don't know where they're coming from, and they're kind of making their way into your office. And this is just it's not a big tool, but you know, there are some guidelines here on how you would manage that, and what are the different roles of folks within the school setting in response to these things. So good tool, and that is available for you at that link. So some quick NASN updates. This is a new course that's just fairly recent. We do get questions of folks who are looking for more information about epilepsy and about seizure management. And this course is called Epilepsy Care Considerations for School Nurses, Stigma and Sudden Unexplained Death in Epilepsy. So this is available to you on NASN. So those of you who are SNO and NASN members, there's no cost for this course. You can click on it. It's available to you in the Learning Center, and this course is available free of charge. Another thing I just wanted to bring to your attention is that, again, we do get questions from folks who would like more information on disaster preparedness. So this is some resources that are available to you on that particular topic. So there's trauma-informed care in school nursing, which is a kind of a course that you could complete that has information on disaster responses. There's a number of tools here. We also really encourage people to take a look at the REMS courses. I don't have a link for them on here. We have talked about them before though, and I just again put in kind of a pitch for them. They have very good quality courses, and they have some that just like this one really focus on the role of the school nurse in response to disasters. So if you're not sure where to access those courses, please send either Elena or I a link, and we'll make sure that you do have access. You get the link if you're interested in the other ones as well. And then all of these are hyperlinks to a variety of resources on disaster resources. This is a very interesting program. I wanted to bring it to your attention because so often, as we talk about school nursing hours and not enough hours for the day, and not in, you feel people feeling like they have a lot on their plates and they're trying to delegate and manage a lot of things. This particular podcast is really looking at some data around what happens around medication administration and some of the errors that occur in regards to medicating kids in the school setting, and kind of links it to how is that affected by school nursing hours, or school nurse access. And so it's not particularly long. You can listen to the whole thing in like probably a half an hour, but it is very interesting. And so I would encourage those of you, who have more interest in kind of pursuing this, to take a look at this or take a listen to this podcast. They have also made the article that it's based on, that was in the Journal of School Nursing, have made it free to everybody. So it is, even those, if you don't have a membership in any organization and you would like to review this, it is available at this link for 60 days. So I would encourage you to take a listen, and also to take a look at this article, just because it gives you good information and things to think about in regards to medicating kids and errors and how to reduce those. So some Washington DOH updates. I'm not going to spend a lot of time on these because they do impact us in a sense, but kind of just more to give you an overview of, as laws change, as national guidelines change, just know that Washington keeps on track with those kinds of things, and that they need to update their own resources and tools as a result of some of the changes that take place at the national and federal levels. So CLIA exempt state status. I'm not sure if you're aware, but Washington State is one of the few states in the nation who is CLIA exempt, which means essentially Washington provides its own CLIA waivers. And so when you are applying for a CLIA waiver, or you're applying to renew your CLIA waiver, you're doing it through the state, whereas many other states don't do that. So we're kind of unique in that. And because there were some federal changes, our process has to change as well, because we are tasked, if we want to manage as a state, if we want to manage our own CLIA licenses, then we must either meet or exceed those guidelines. And so there are going to be some changes made to it. They aren't going to impact schools a lot, but I just wanted to make sure that you are aware that you may see some changes coming through, perhaps regarding quality control measurements, and things that they might ask you to report, or that your forms might take on perhaps a little bit different look, or have little different components to them. And that's why that is resulting. That's what that is about. Some other changes that you're going to hear about, again, these are through rules changes that are taking place around immunizations. So again, just like with CLIA waivers and trying to meet other guidelines, the rules around immunizations have to do that as well. So they rely on things like, CDC guidelines and other guidance when Washington State is making decisions on immunizations. So there are some kind of language, you're going to see language changes coming down in these immunization WAC codes. So there will be some language changes in there, but in reality, some of them are actually going to be improvements from a school standpoint. Not huge changes, but definitely improvements. What you won't see, though, are going to be changes in the actual vaccine preventable disease vaccine requirements. So that WAC code 105030 is one that has been brought to people's attention. They want to make, there's groups out there who want to make sure we don't, for example, make changes to that list and that we don't add COVID vaccines to it, for example. There were concerns about that and people expressed those concerns to the state, and they just put out a notification saying we aren't adding that. That is not, COVID vaccine is not being added. There is no change to that WAC code on school requirements. So the group that they're really looking for in making these changes to the immunization WACs is the advisory committee. So you can see it's called ACIP, abbreviation. It's the Advisory Committee on Immunization Practices. So if you are interested, you can take a look at the article and it's going to explain, what are those current guidelines. Just came out recently in the September issue of MMWR. And so you can take a look and see what that says, but it isn't really going to change our practice. The WAC code that will change our practice the most is really the one about timing, and that's 105060. And for some reason in the past, and I don't remember the rationale, but it's still, if you pull it up, had language in there that said everybody was going to report their immunizations by the 1st of November every year. But that isn't really what Department of Health does. They report. So if you read that, don't panic and think, oh my gosh, that's what the WAC says. So therefore our reports are due November 1st. That is not the case. They're actually going to change that language to simply say the reports will be due when we decide and let you know that they are due. And for us, for this school year, that will be the 1st of December. So just know that your immunization documentation will need to be going into Department of Health by December 1st. Safety study hall. So this is just again, this is related to legislature. So House Bill 1230 passed a while ago, and what it said was that we needed to get more information out to families and our students that is related to health and safety. And Department of Health responded to that. They were tasked with it, and so they responded to it by creating this great webpage called Safety Study Hall. It just got launched this last month, and right now it has 3 main topics on it, and those are opioid overdose prevention, secure storage of prescription and over-the-counter medication, and secure storage of firearms and ammunition. Now, based on the legislature, we need to provide this information to our students on our on every web page. So not only does our school districts tasked with that, but also the ESD is tasked with that. So we need to provide links to this particular page. And so you'll see it like right on our main public health page. We have a link to the safety study hall, and other school districts are now starting to add this right to their homepage to get people access quickly to this type of information from the Department of Health. So the link is here. If you need help, if your district needs help, please reach out to us at the ESD. We'll be happy to help you make that happen. So. Okay, so Washington Center for Nursing, I think I just have a quick update from them on something called the Clinical Placement Initiative. So these are conversations that are going on. We have a variety of groups in Washington State who are really focused on the recruitment and retention and development of nurses. And that involves nurses at for every type of position, but certainly we're very interested in how on earth we are going to be able to recruit and retain school nurses. So that's interest in across the state as well. So a series of sessions have been set up where the Washington Center has been collecting data from folks in the state of Washington and coming up with ideas and strategies for how we could focus on, in this case, clinical rotations. Because one of the problems we face is that if we were to increase the volume of students coming through, where will they complete a rotation? And that clinical rotation sites would include school districts. And how can we increase the volume of rotations as well as make high quality rotations for a variety of students? So the next session, they're looking for input from people from nurses, whether you are a faculty at a college or you are at the school district and you have input on how to expand and develop clinical rotations at the schools. I'd love to hear from you. The meeting is going to be November 14th for our region. So this is being done regionally across the state. And our particular Central Regions meeting is November 14th from 1 to 3 o'clock. And if you want more information about this, you can click on the Washington Center for Nursing. It'll take you right to the page that describes this program. And we do ask that you pre-register for this. So there's a link down here at the bottom to register attendance at that event. Okay. Washington Board of Nursing, one update from them, and this has to do with their frequently asked questions page. So they're always updating information on that page. And so one of the things I just wanted to call your attention to is their expanded information on school nursing, particularly school nursing delegation. Because lots of people have questions about school nursing delegation and trying to understand it and to answer people's questions about it, who don't understand delegation in the school districts. And this is just a snapshot of the questions and answers that are available on this page. It's much longer than this. And so as nurses ask questions to the Washington Board of Nursing, one of the ways they respond to those questions is by adding them to these frequently asked questions. So please look here first. There's a variety of topics on their webpage, and take a look and see if your question is not answered here first. And if it is not, then there is a mechanism for you to send them an email and ask them, and they will get back to you. Okay, some additional training and resources. Well, for those of you who are interested in more immunization, oopsie. Well, let's see, how do I go back? Well, I don't know how to go back, so I'll just tell you. There is a 1-hour presentation tomorrow by Washington Department of Health. So if you're interested in learning more about immunizations, it's a Zoom event, and it is going to be, you can access it on our calendar. So just go to the school nurse calendar. It's from 12 to 1 tomorrow, and it is going to be an overview on immunizations and how to help families kind of convince families about the importance of immunizations. Another program that's coming up through the Department of Health is going to be their health and safety update. They just did one in September, I believe it was in September, and that was in Spokane, and it was available in person or via Zoom. And they're doing another one in November. It's November 7th, and it is going to be from about, I don't know, I think it's like 8 to 4. I will tell you, these do tend to end early because the afternoon session is at times is more specific to the region. And so the overview of the other parts of it, the environmental health aspects of it, are usually covered before lunch. And those are really of the most interest. And so that November 7th session, you could go in person, but it's in Renton, or you could attend that via Zoom. And again, that is in the school nurse calendar as well as the registration link. Washington DISH, Diabetes and School Health. So just a reminder. And again, our next session is tomorrow. So if you are interested in that, it's going to be talking about glucose management. So how to prevent those highs and lows in the school district during the day. And then you can see the schedule. And all of those are 3 to 4 o'clock, and you'll find them on the calendar. Then best extended learning sessions, our program on school nurse mentors. We have one January 13th and one June 9th. Anyone who is interested in developing mentoring skills is welcome to come to those sessions. And then our roundtables are monthly, almost every month except for April. And those are from 2 to 4. And all of our trainings that are available to you are posted on the school nurse calendar, including the registration links that'll take you right into PD Enroller. You certainly can also search through PD Enroller as well. Okay, I'm going to stop sharing because my 30 minutes is up. Does anybody have any questions about anything? So quiet. Any questions in the chat? Nope.
Nope, I'm not seeing any questions in the chat. Ben has his hand raised though.
Ben,
I was curious on the NEFI, for the standing order for the NEFI. That one, that would be good for staff members and stuff in the building or people that had not been identified and so don't have orders with that whole standing order thing. But is that going to be exclusive, like for the kids that have a prescription for an EpiPen, but they don't get it to the school in time for an event where they needed that? Is that NEFI going to cross over, or would that be something where the doctor would have to say that they can use the NEFI?
I would recommend calling the doctor and let him know what you have available in the school. Because the student's probably could come in with an order for injectable as their route. So just let them know this is what you have available to respond and why you have that, because it makes it's so much easier for unlicensed staff to administer that medication, and just make sure that they're aware.
Do you think we'll see a change in the option for teachers or whoever to give to undiagnosed students because we have a nasal spray versus an injectable?
That's an excellent question. I don't know if that will come down the pike or not, but certainly it is so much easier, at this point to administer epinephrine now to people. There's always, I imagine, some concern of, is a person able to assess the student, because unlicensed folks can't really do an assessment. So right now, if would be calling 911 if the person doesn't either have the medication or there's no one to administer it, whatever route you have to them, then, their next best thing is calling 911 if you don't have it. But that could happen.
I just see the questions coming because Narcan they can do.
Right.
So they can quote assess that, if you want to call it that, but they can't an allergy. So I've already had that question. And then if we start to see a nasal spray, I can see the question, okay, then why can we do one and not the other? Because the same words come out of my mouth that if they get the Narcan and it's not an opioid overdose, as we heard from Garth, it's not going to hurt them. But we also know the same thing about if it's not an allergic reaction, the epi's not going to hurt them either. So I just feel like it's kind of coming out of both sides of our mouths, and it makes it harder for teachers to, what do you mean?
Yeah. And the anaphylaxis guidelines are under review, and it'd be interesting to see what the final decisions are around the use of NEFI.
And then albuterol inhalers are next, right?
Yes. Let's hope. Okay. Has Dr. Wallace joined us, Leda?
I haven't seen him come up on our list of participants here. I haven't seen him join us yet. Sheila, am I missing him somewhere? No? Okay. But I do want to give a quick shout out to Oscar Benavente for joining us at the last minute as well from Neuralis, and going to talk to us about Valtoco. So I can send Dr. Wallace a quick email and see if he's going to be joining us today. Did anyone have any other questions for Kathy?
Yeah, this is Lexi from the Grand County Health District. I am the immunization coordinator there. I was listening to you talking about the family immunization on the school nurse calendar. I don't have access to that. Would I be able to go to that since I'm trying to work with the schools, or how would I go about that?
Thank you, Alexis. I don't think there's any lock on it. I mean, I think it's just a link. I think you just need the link.
Okay, awesome. Thank you.
Yeah, we'll get you the link and then you can just log in. It's really a Google, it's really just a Google Calendar. So as long as you have that link, you can log into anything on there.
Okay, awesome. Thank you so much.
Yeah, thank you.
Okay. Oh, thank you, Michelle. So anyone that has access to the internet can go onto the NCESD website and onto our School Nurse Corps webpage. Excuse me. And Michelle just linked it as well. But we have a calendar of events on there with links that you can utilize to have access to all kinds of resources on there. So thank you everyone for putting that information in the chat for our guests. Right. So I am seeing, sorry, I am having a hard time typing and looking and doing multiple things at the same time. So I appreciate your patience, everyone. I just saw that we have another participant, but I was checking to see if it was Dr. Wallace. Are you on here, Dr. Wallace?
Yes, he is.
Oh, he is. Okay. I'm just having a hard time seeing him. There's lots of names. So, Dr. Wallace, if you are ready, we're ready to turn the time over to you. Good morning. Good morning, Dr. Wallace. Thanks for joining us.
Good morning. Sorry, I had a Zoom marathon this morning already. How are you guys? Sorry, are you able to hear me?
Yes.
Yes.
How
Good.
are you?
Doing well.
Good.
Racing on Zoom all morning. Sorry, I'm a little bit late. Let's see. Yeah, I can start. Don't have a huge presentation today, but got some slides I'll share. Hope everyone's off to a good school year.
Feels like it's going fast.
I couldn't agree with you more. Let me see if I can move windows around so I can see you and talk at the same time. Oh, what's the best way to do this? Hang on, sorry. Yeah, how's that? Are you able to see those slides that I put up?
Yes.
Great. Well, good morning, everyone. Hope things are going well. I certainly want to hear about it from the public health front if they're not, and do the work that we can do as LHJs to support you guys. We are launching. Oh, it's not advancing for some reason. Let me see.
Whoops, you're advancing.
Yep.
There
we
you
go. Okay. It's making me drive it a little bit different today. So kicking off our respiratory illness season, we are starting to see an uptick in some illnesses. So I want to give folks a update on surveillance and epidemiology and things that public health and healthcare partners are doing to prep. And then, we're watching closely a lot of illnesses that are emerging or re-emerging, given local patterns and what the population is experiencing. So I thought I'd talk a little bit about chickenpox because it pops up a lot. Sometimes just individual cases, but oftentimes it's something we worry about for outbreaks. So I thought I'd just run through that illness in particular briefly, and then hopefully we can talk about collaborative responses. As far as respiratory illness goes, we're tracking and watching closely for upticks in influenza, RSV, COVID. The western part of the United States is not seeing as much influenza start to pick up as eastern states are. If we look at our rates regionally, these graphs are from North Central Washington, and I think we all experienced an increase in COVID in August and September. We peaked as far as emergency room visits go, just as high as we had in January, February, in the middle or beginning of September. And has seen a slow decrease in people accessing emergency rooms and hospitals for COVID. But it's certainly still out there. I diagnose a couple of cases a week in clinic, and so we're watching it, and hopefully the rates continue to trend down. But with wintertime coming, expect to see increases. I've diagnosed a case of influenza in clinic in the past 2 weeks. A couple of my partners have too. And so we anticipate those rates are going to start rising. Haven't been informed of any hospitalizations, but certainly see both influenza A and B pop up when we have conversations with our healthcare partners. So preparedness activities are certainly in place. All healthcare partners I've spoken to have influenza COVID vaccines available. I know some have been collaborating to do staff and other outreach vaccine clinics. Reach out to local clinics if you're interested in that. But I've been working with healthcare partners to ensure vaccines are there, and efforts are taken to get folks in. So hopefully access is not as much of an issue as it has been in past years. Now is certainly time to go ahead and get influenza and updated COVID vaccines as we enter into a season of greater activity. And then working closely with healthcare partners on their infection control strategies, outbreak response. We've seen a couple long-term care facilities with COVID outbreaks, and we're working closely with them to minimize spread, especially to highly vulnerable individuals, and then work with hospitals and clinics as they see cases either in their patient population or oftentimes in their staff, and working to try and decrease transmission within clinics. And so talking about when and how to mask and how to watch local rates as well as rates among staff members. And so a lot of the healthcare partners have become really agile at how they track illnesses through their organizations and respond with masking and heightened infection control practices. We are watching a lot of diseases on a global level. So folks may have heard of Mpox, Clade 1 and Clade 2 emerging, usually out of Africa, but with global distribution, see Mpox pop up a little bit more. We watch it in Washington. There's a vaccine, and the majority of the cases we see are transmitted through sexual activity, but it certainly has the possibility to be a contact spread. And while it's rare and cases are low right now, it's something we watch closely. There's a Marburg virus outbreak. It's a zoonotic illness that comes from bats and is being seen in Rwanda right now, and so there are travel advisories, and folks are watching that closely. No cases outside of Africa right now. No cases in travelers to Washington State from Rwanda or impacted areas, but that's something that we've been advised to watch closely. And then avian influenza currently is still something that we're seeing in waterfowl, in domestic flocks, as well as in cattle across the United States. There have been a couple human cases, but no human-to-human spread. So watching that real closely, and public health systems are prepared to monitor and support individuals that are impacted by that. But no reason to be more concerned about avian influenza than we have been in the past 2 years, but it's something we're tracking closely. But then we have been seeing what we call re-emerging diseases that we have been familiar with, have fortunately not seen as much of, but that are resurging. So vaccine preventable illnesses like measles, pertussis, varicella are cropping up in individual cases, and more commonly in outbreaks where either through travel or distribution of folks from areas that don't have as great vaccine practices, especially countries that are impacted by political and socioeconomic challenges. Oftentimes, our refugees, asylum seekers come and still have difficult time accessing healthcare services as they settle. And oftentimes we see measles pop up from travel and then get into populations that are under-vaccinated and spread. So we've tracked cases closely throughout 2024. We've had some cases of measles and outbreaks in Clark County, Spokane County, watching that very closely. We've talked a lot about pertussis because we had the outbreak in Chelan and Douglas counties earlier this year. Fortunately, have seen that go down, but have seen more cases in Grant County of pertussis. And I know Grant County Public Health is working hard on that and helping to identify, treat, and prevent the spread of those cases. Varicella is one that is a vaccine preventable illness. Many of us who came along before the 1990s when the chickenpox vaccine came out had varicella, had chickenpox. Usually it's not as severe of an illness, but to high-risk individuals, it certainly can be much more complicated. And so fortunately, we've seen a lot fewer varicella cases, fewer outbreaks, and fewer cases of cause for hospitalization, the pneumonia, encephalitis, and long-term sequelae of chickenpox. But I thought I'd review it just because it always pops up as a question when somebody shows up with a fever and a rash. And I think in health rooms, it's going to be something common, and oftentimes could be the first place where varicella is detected. So it's a herpes virus. It's the same family of viruses that cause oral herpes and other forms of herpes. It's a big virus. It's really stable. It's a DNA virus and is large compared to smaller viruses like influenza and COVID. But it enters into the patient's bloodstream through respiratory secretions. It's airborne, and so is highly contagious. And can set in the body for 10 to 21 days before symptoms and an infectious period starts. It typically begins with upper respiratory symptoms as the airways are first infected. But then as it spreads, it gets into nervous system and skin, and then pops up with the characteristic rash. So the rash is typically first red, flat macules on the face and the trunk, and then the extremities. And over 2 to 3 days, those flat macules turn into pustules. So raised red lesions that are very itchy and contain fluid, and that fluid itself is contagious. And then in 5 to 7 days, those lesions begin to open up, turn into sores, then crust over. And the virus is transmittable and the patients are infectious for 48 hours before the rash occurs to 5 to 7 days after the rash starts and after the lesions all completely crust over. It's a tough one to identify initially because it initially presents as mild upper respiratory symptoms, cough, sneezing, runny nose, and a fever. And then a day or two later, the rash develops. So it's a great one to advise students and staff and patients in general to remain at home with the onset of upper respiratory symptoms. Return if those symptoms are improving after 24 hours. But if you develop a fever and a rash, that's a sign that there's a more severe illness at play and should prompt that individual seeking healthcare. The rash is usually the most severe health impact. It can spread throughout the full body in folks that don't have up-to-date immunity, aren't up-to-date in their vaccines. And then those lesions can, as they open up, develop bacterial superinfections, especially group A strep. It causes impetigo, but then can disseminate into invasive group A strep disease, which causes meningitis and other organ illnesses. Varicella can cause neurologic complications, so you can have encephalitis, transverse myelitis, ataxia, where it's really difficult to walk, and for those reasons, individuals have to be hospitalized. Pneumonia is less common in school-age children, but certainly affects infants, and the pneumonia is more common in adolescent children and adults. So the majority of cases of pneumonia are in older folks, again, who aren't up to date on vaccines or haven't had it before, and have a more vulnerable immune system. So those extremes of age are more susceptible. And then it's a dangerous disease in pregnancy because it can, through the viremia that can pass through the placenta to the fetus, can cause birth defects and illness at the time of birth. And so we need to be especially protective of individuals that are pregnant and that might be exposed to varicella. And then anyone with either medications that they take or medical illnesses that cause immunosuppression, oftentimes they do not respond as well to the vaccine and are more vulnerable because of that, or have immune systems that have suppressed cellular immunity and don't respond to vaccines quite as well. Infection control is really important because of the likelihood of airborne spread. So the droplets that are secreted when people are coughing or sneezing can be aerosolized, and the attack rate or the ability to affect people around you is really high, almost as high as measles, but that attack rate is as high as 90% in families and groups of people that are not vaccinated. We recommend that anyone with chickenpox be referred to healthcare, and especially important for schools that might suspect that a student or a staff member has chickenpox, notify the healthcare clinic prior to their arrival, because the healthcare clinic needs to follow their protocols to either room patients immediately so they're not waiting in the waiting room, or see the patients out in a car, or whatever practices they use for folks with communicable diseases. The staff members at a healthcare clinic are going to gown up, use N95 respirators, and provide care, but do so to prevent spread to themselves and to other people in clinic. It is a clinical diagnosis, so you can diagnose chickenpox because it has such a specific pattern without testing, but we really encourage healthcare providers to get a PCR and confirm the diagnosis with lab results because that helps us in our outbreak investigation and our contact tracing, and certainly helps to confirm the diagnosis. Unfortunately, treatment is really just symptomatic, and that goes well for folks with just the typical upper respiratory symptoms, fever, and rash. So acetaminophen and ibuprofen are appropriate. It's important that people don't take aspirin-containing medications when they have chickenpox because that can lead to Rise syndrome. And so it's one particular illness that we make sure people know not to take aspirin with. We certainly treat or provide precautions for individuals to seek emergency room or hospital care if their illness is progressing. But typically, after 5 to 7 days, the rash crusts over. Hopefully, there's no bacterial superinfection, and individuals are no longer contagious until that rash does crust over. The good work that we do with schools and the work that we really appreciate is getting notified. It's not a notifiable condition in Washington State, but it's certainly helpful to be aware for us at Public Health to be able to notify our clinic partners, be able to make sure that individuals with suspected chickenpox can get in to be seen, to be tested, to be treated as appropriate. And then for us to conduct an investigation in the school setting, in childcare settings, or other settings where people are indoors close together, identifying when and where there is an outbreak, and enables us to support individuals in prevention. There is the ability to give immune globulin to people that are not vaccinated and are higher risk for disease. So we would use that for young children. We would use that for individuals who are pregnant or have immunosuppression. And so knowing who those high-risk individuals are in the context of an outbreak is very important. When we know of an outbreak, we're certainly able to help the school or the child care facility or whatever potential points of contact exist to heighten their infection control strategies, the disinfection, the control of airborne spread, and exclusion for individuals that are infected or at higher risk. We want to be able to support and provide guidance, coordinate with our partners, and then help with communication as well, because oftentimes when there is an outbreak, communication needs to go out to parents or other community organizations or community members, and we can help support that. So the earlier we know about it, the earlier we can help. And then we really want to help healthcare partners, schools, and the general public ensure that they can maintain their status for vaccination and be up to date to prevent further spread. Chickenpox is the vaccine, the 2-dose vaccine that kids now get is 90% effective. And so it's really good at controlling the spread, limiting the degree to which outbreaks occur. And so we want to help support in outbreak circumstances, vaccination for anyone that doesn't have immunity, but also just maintain up-to-date status on all vaccines. So that's what I had to report. I'm happy to answer questions specific to chickenpox or other vaccine preventable illnesses. I wouldn't be surprised if we see some. So want to support the good work that you guys do, and just be a strong resource for you guys.
Thank you, Dr. Wallace. Does anyone have any questions or comments? for him.
So I'm able to open the chat now that I closed that other screen. So it sounds like schools have already seen some influenza. Not surprising, and glad that that was quickly identified. I know Grant County really has a strong communicable disease response team, and I hope they've been helpful. Amber, do you want to share with anybody the experience you've had with influenza in some of your schools?
Yeah, it was the school nurse. She reported right away they had 10 out of 16 kids plus a teacher absent. And so she called us right away. And at that point, no one had gone to the doctor. So we encouraged, somebody to get tested for COVID, because we assumed that's probably what it was, because it was pretty early for influenza still, and symptoms, sounded pretty COVID-like. So she was able to get the teacher to do a COVID test, which was negative. And then simultaneously, a student was brought to their provider by their parents, and they were tested positive for influenza A. And we got a copy of the report, so it was confirmed. And then that was a couple of weeks ago, and the kids all slowly started coming back to class, and there weren't any. I think 6 out of 10 was the most that were out that during that outbreak. And she didn't see any other classrooms with abnormally high absenteeism. So it seemed to be somewhat, from what we could tell, isolated to that classroom. So haven't heard anything since. So that was, credit goes to the school nurse for picking up on that and notifying us right away. So we did send out exposure letters to the classroom so that parents knew what was going on. And didn't hear anything from parents, but like I said, no additional sick kids. So it looks like at this point, I think we're past our 7 days, so they're probably out of that outbreak. But that's what we've seen so far. And then just the sporadic, we do get reports from several clinics, facilities here in Grant County that voluntarily report their positive flu tests to us. Just numbers, not people, but just so that we can keep track of those. So we're definitely seeing an uptick here in Grant County. So.
Great. Yeah, not a surprise that it's something we're seeing more of, and it sounds like great collaboration there. We really appreciate it when we get the call from school nurses and the report, but also the invitation to help. So please contact LHJs. We enjoy the opportunity to help out and want to do anything we can to support the work that you guys do.
Yes, I echo all those sentiments.
Great. And yeah, Michelle, thanks for your recognition that vaccine exemptions are up. Exemptions are allowable for medical reasons or religious reasons. And we see a good bit of that. And so we know that there are a lot of folks that are going to be more vulnerable. And so all the more reason to make sure our practices are sound and we can keep those more vulnerable kids safe and respond appropriately when we have illnesses roll through schools or roll through healthcare organizations or places of employment, and we can support those more vulnerable populations. And then Kathy, thanks for sharing that link. I think one of the more concerning things that I think you can see in the data is that there are higher rates in some districts and some regions of staff and kids and folks that don't have exemptions and aren't up to date on their vaccines. And that's something we'd love to help close the gap on if there's any work that public health can do, either in holding vaccine events or collaborating with healthcare partners to make access to vaccines more available. In just the past couple of weeks of discussions with healthcare partners, I think there's the perception that access is there and people that want to get vaccines can get in. But I know both as a parent and a healthcare provider, sometimes access is not as easy as it ought to be. So if the staff members and students are having a tough time getting into a healthcare provider, you can certainly reach out to local health jurisdictions as well, and we can help facilitate that.
Thank you, Dr. Wallace. That would be wonderful.
Yeah. Just let us know if students are really having a hard time getting in to get vaccines and be up to date for their age, especially in kindergarten. But I think all ages, we can find that people are behind and need to get them caught up.
So pre-COVID, as we refer to everything in life, I think now, the Chelan Douglas Health District had options where we could have flu clinics for students at the schools. Is that something that we're getting closer to having the bandwidth to do again? Because I know, at least where I'm at, if it comes to us, the kids get it. If it doesn't come to us, it happens a whole lot less. So we had statistically enough kids that did it that made it worthwhile for us to do it.
Okay.
But I totally understand that as an LHJ through COVID, none of us had bandwidth to add or do that.
Yeah, let me talk with Stephanie, our vaccine coordinator at Chelan Douglas, and see what capacity there is for that. And Michelle, I'll follow up with you.
And also just know that Caravan is available. I think I'm in chat. So like if they may also be in town, we can do it.
We've had some requests for that in Methow Valley too.
Mm-hmm. Yeah, the mobile units are perfect, when we can get them. It's really a great option. Sometimes it's a little difficult though to get them to come. So.
All right, let's see if we can make that a little less difficult to get them to come.
Thank you. Thank you.
Thank you so much. All right. Thank you again for joining us, Dr. Wallace. And
yeah, thanks everybody.
We appreciate your time with us in the review over chickenpox. It's always good to keep that information fresh in our minds. So
great.
If you have any other questions that you want to relay to your LHJs, please reach out to them. We can get you connected with Dr. Wallace or anyone at the LHJs that if you don't have their contact information. And also, I know that Amber and the folks at Grant County have put their contact information in I believe they put it in the chat. If not, we can connect you with them as well. So thanks again, Dr. Wallace. It was great seeing you.
Thanks. You guys have a good day.
All right. So our next presenter is Oscar Benavente. And Oscar, did I say your last name correctly?
Yes, you did. With an English accent, but yes.
Okay, sorry.
No, I love it. I love it.
So Oscar works he's the territory manager for Norellis, and I hope I'm saying that correctly as well. I got to meet him at the Snow Conference this last weekend, and he helps to bring Valtoco to schools and to students that are suffering from seizures. When Kathy presented, she put out some information about seizure management course at NASN, and that would be an excellent thing to review and utilize or to learn from. But having Oscar on gives us a method of being able to help with that management. So I wanted to invite him and also thank him for coming on at the very last minute. And we don't normally do that, but Oscar, we're so grateful that you have some time today to be with us. And so I'm going to turn the time over to you.
Yeah, let's kick off the meeting. Thank you again for calling me and reach out and invite me in this meeting. I'm super grateful. As I mentioned in your email, I really like to see how school nurses, there's like tremendous advocates for patients and for students. I really like that. As a member of Neuralis, we always we love to work with the school nurses. We do it all around the country since we launched this product, and it's great how we're trying to change the paradigm of how we treat them, and we treat emergencies, right? In terms of epilepsy. So yeah, I have a quick presentation for everyone here today. So I'm going to share my screen, and let me know if you can see it. Can you see my screen?
Yes, we can.
Awesome. Okay, so this presentation is kind of like a general information. It's meant for the adult population, and also for children's, because the indication of this medication is for 6 years and older. So that's one of the important concepts to have. So also right now I want to talk a little bit about the safety information. So when it comes about safety information of Valtoco, we have to keep 3 things in mind. Is that like the use of Valtoco is diazepam, right? And it's a benzodiazepine, and the interaction with opioids can profound sedation, respiratory depression, coma, and death. And also the other parties exposed to Valtoco or the overuse of this medication can also lead to addiction and abuse, and also overdose and death. And the other one is the dependence part of the benzodiazepine. So that is the other risk part of this medication. If you have more questions about, you can find all the rest of the information in the PI. This part is meant for adults, so I'm going to skip this part of the presentation. But this is one of the areas that I want to cover. Prepare your patients for the immediate use of seizure medication. So the more time we wait to administrate Valtoco, the more risk is that the patient is going to go to a prolonged seizure or status epilepticus. So the immediate use of Valtoco is to prevent emergencies, right? To control the seizure in place and avoid to call the emergency room. If the patient is seizing for more than 5 minutes, we should call the emergency room. I don't know how you have your seizure action plan. That's something that we can discuss here today. Treating early is what we want to do with seizures. It's something important to keep in mind about seizure rescue or immediate use. Is 60% of seizures, they stop within the first 2 minutes. But after 2 minutes, is the chances that it goes to prolonged seizure, they start to increase. So right now with Seattle Children's Hospital or with the neurologist, they're established, and we should administrate Valtoco if the patient is seizing for more than 2 minutes or 3 minutes, between 3 minutes to 4 minutes. And that's something that it can be discussed in terms of like the seizure action plan. How benzodiazepines, they work to stop seizure. They work over the GABA receptor. So when a seizure is happening, the GABA receptor, they start to show up around the threshold in the neurons, and they work over the GABA receptors. They help the GABA receptors that are the brake in the brain to stop the seizure, and the benzodiazepines, they help the GABA receptors over time to stop the seizure. And this is really important as well. Why? Because the GABA receptors, the GABA A receptors, that are being used when the seizure is happening. So the sooner we administrate Valtoco, the sooner we can stop it, because there are more GABA A receptors available in the brain to work on. So when you wait too much, there are not going to be any GABA receptors in the brain to use to stop the seizure. So it's going to take longer to stop it. That is the kind of like the science part of behind how benzodiazepine works. So how Valtoco works in our clinical trials in the phase 3 and the study 5, we have 3 different conclusions, which is like it's rapid, reliable, and ready. So rapid is in terms of like time of seizure cessation, how long it's going to take to stop the seizure after we administrate it. So the median cessation, it was within the 4 minutes after it was administrated. It's important to keep in mind though, then Then Baltoco was administered. Some patients, they administered Baltoco right away within the first minute. Some patients, they did it after 5 minutes. Some patients, they did it after 3 minutes. Some patients, they did it even after 30 minutes. In the median, it was 4 minutes. We have a post hoc study that is going to show, I'm going to show later, what is cessation, the median cessation if we administer Baltoco within the first 5 minutes. And as you can see there, the median is 2 minutes. So that is relevant information, and that is the reason we encourage doctors to tell to the parents if the patient is ceasing, you need to administer Baltoco with like sooner than later, right? Reliable. 87% of seizures, and they were controlled over the period of 24 hours. They need only 1 dose. So every box of Baltoco is coming with 2 doses, like the main doses. We have 4 different strains that I'm going to explain later. But the 87% of those seizures, they were controlled with only 1 dose in the period of 24 hours. Why is this relevant? Because in cluster seizures, we try to stop, and the patient has a second seizure emergency, and this happened within like after 6 to 12 hours and 24 hours, they have more risk to have a second seizure, a second emergency. So the half-life time of diazepam is 49 hours. So this is really important because protect the patient for the next 24 hours. The patient is protected, is a shield that the patient gets when the patient is having cluster seizures. And this is the second part. The third part is 1 hour. So patients, they recover within 1 hour, they come back to themselves. So patients, when they have cluster seizures, and they have those seizures and they're different from the rest of the seizures, they lose entire day. Maybe you have seen this maybe with some of the kids. They have a seizure, they go home, and they lose the entire day. They can't recover from the first seizure. In this case, we have learned this with experience, then, right? But when we give Baltoco to patients, they have some somnolence, but they report they come back to themselves within an hour. So if you have patients, and this is Stephanie Randall spoke about this in her presentation in Snow, she say, if you have a patient, they have a seizure, you administer Baltoco, leave him for an hour sleeping, and then he can come back to the class. That's what she's saying in the presentation, and that's what she's been trying to educate parents and school nurses about this part. And it's interesting because I hear in the Q&A that and after I have some discussion with some school nurses, then even when they administer Baltoco, they still call the emergency room and they send the patient home. This part is like where we trying to change this area, and Stephanie Randall is very strong about that concept. Like you don't need to send the patient home. Obviously, that conversation needs to be established with the parent, but that's what the data is trying to explain, right? What is this clinic, like the study, and how we did this? So we controlled 175 patients. 163 patients, they received only 1 dose. We control over 4,000 seizures in this study. And the study, it was for, we did it in 2 phases. Like phase 3 was 12 months of enabled repeat dose. And the primary objective, I should have started with this area, is assess the safety and tolerability of the Baltoco, how safe it is. And that is, I'm going to move to the next part. So this is what I mentioned before. If the cessation is 4 minutes, but the median cessation when you administer Baltoco within the first 5 minutes, the median is 2 minutes. So the sooner we administer Baltoco, the sooner we stop the seizure. And that's like here we're repeating the same information. Administrate earlier is the best. Here is the reliable part. How many seizures they were stopped only with 1 doses. You see there is we control around over 4,000 seizures, but the total was some of those seizures they were excluded in the study, but we control 87% of those seizures with 3,368 seizures that were controlled with only 1 dose. That is strong because that is explain the efficacy of Baltoco. And this is like the next part is how it takes long patients to come back to themselves. This is really important because we give Valtoco to patients ictal and periictal. Which that means is when the patient is ceasing or right after the seizure. Why is that? So some patients, they experience a seizure and they feel that they're going to have another one. Like, oh, I have a seizure. This one lasts for 1 minute, but I feel I'm going to have another one. And the question is, can I self-administrate Valtoco, or can I administrate Valtoco right after the first seizure? The answer is yes. You can prevent seizures, but you can do it right after the first seizure. And this, the mention here is like patient come back to themselves within an hour. They recover really fast. And this is like some side effects. So the biggest side effect, and we present in our studies, nasal discomfort, dysgeusia. Dysgeusia is this weird flavor in their mouth, and kind of like a metal flavor, right? And epistaxis is like blood bleeding, like so nose bleeding, which was at 2%. 1.8 treatment patients reported somnolence. We didn't present any SUDAP or respiratory depression in our study. This is the PK study. This is like just to compare the max dosing and the half-life time, which is and how compared with the bioavailability. The bioavailability of this product is 97%. So this is really relevant. So bioavailability is the amount of concentration that go to the target tissue. So when it comes about Valtoco, 97%, if you give him 10 milligrams to a patient, 97% of that is going to the target tissue, which is in this case, the brain. And that is enormous because that is really, it makes this product really available in the brain to work over the GABA receptors, which is what we really want. And this is the part I think is really relevant for everyone here is the dosing. So for school nurses and for majority of pediatrics, we see always the 5 milligrams and the 10 milligrams. That is like pretty much the universe of you guys. For adults, normally it's 15 and 20 milligrams. But yeah, we will see the 5 milligrams and 10 milligrams most likely in pediatrics. And it makes it easier for you in terms of administration because it's only one device in one nostril. And the second device is just the backup. It's important to mention this part and why, because many times when you have a patient and a student with epilepsy, they give you only one device with 5 milligrams. They don't give you the backup. They should give you the entire box in case the patient is ceasing within the next 4 hours, after 4 hours or after 12 hours, or in the next 6 hours, the patient has another seizure. Most likely wouldn't happen because as I say before, 87% of those seizures, they were controlled with one dosage. But it's important to mention this area to the students or to the parents, then you need the entire box for one patient. One patient requires the entire box and you need to keep with you to have the backup dosing. And this is just more informative in terms of how you put the medication in the EMR system. So here, Valtoco, for example, 10 milligrams, 5 boxes. So we have a quantity limit, then the patient, they can treat how many emergencies or how many episodes they can be controlled for months. So we can control up to 5 episodes per month with 10 doses, right? This is more because the risk of benzodiazepine is because it's a controlled substance. So normally doctors, they prescribe between 1 to 3 boxes. That is the average. I will say then, in this case, for pediatrics, patients, they need more than 1 box. I will always try to recommend to go for 2 boxes, one for the school nurse and one for home. If the parents, there are so many different situations here. Like sometimes parents are divorced, so 1 box for one parent, 1 for the other one, and 1 for the school nurse. That will be required 3 boxes, right? So that is it can be, you can customize and you can have a conversation with the parent depending what is the need. But this is pretty much how you put it in the system, and you can complete those you can customize or you can add the rest of the information in the notes. In terms of like use, patient, there's 90% of patients, they say that it's extremely easy or very easy to train others or to administer Baltoco, and 79% of patients were very comfortable doing activities outside of home with Baltoco when Baltoco is available. This is tremendous because having seizures for adults, for example, some of them, they're scared to say something because they can lose their drive license. For parents, before Baltoco, we have we have the rectal gel, diazepam, or Diastat, and here everyone knows about it, which is just the rectal administration, which is not friendly. Patient, they don't want to, for example, for kids, maybe someone who is playing soccer, or in my case, and I used to love to play soccer when I was a kid, or like basketball, any sport, they're more uncomfortable to do those activities. This incremental the satisfaction of doing activities outside of home when you have Baltoco in your pocket. Again, some of the just the safety information of Baltoco, as I mentioned before, and some contraindication. Baltoco as a benzodiazepine is a CNS depression, so depress the central nervous system. Suicide behavior. This is for some patients that they experience glaucoma. You will see more of that in adult patients. It is not every single glaucoma is just open-angle glaucoma, which is another type of glaucoma, and neural sedation or withdrawal syndrome, and also the risk of use of with alcohol. Any questions?
Oscar, I have a question.
Yes.
After administration to a student, the delivery device, that's just like a plastic cartridge, correct? Is that something that we can just throw away, or how do we properly dispose of that? And
you can just throw it away. It's just you have to just dispose it. Normally, it's just garbage after that. You can the expiration of Baltoco is 27 months. So when you get a box, you can keep that box for 27 months. But after use, you don't need it anymore. You can just put it in the garbage.
Does anyone have any other questions? I'm looking through. Oh, sorry, and I'm not seeing any questions. Right. Well, I can tell you that such a delivery device for seizure medication has been a game changer for a lot of students.
We have seen how patients they really like, and how doctors also, and how school nurses they really like Baltoco. And this is what I always try to talk to everyone. I hear someone say something. No. When you see patients, so something then in terms of coverage and pricing, something I think is really relevant. There's a lot of doctors, then they don't know how available is Baltoco in Washington State. Right now, Baltoco is preferred for Medicaid patients. So, which means like they can get it for free. Patients that they have Diastat and they're older than 6 years old, please have that conversation with the parent that this medication is available, because many times they don't know about it. And they can, that is a really easy switch because it's the same molecule and it works faster and it has better bioavailability. So in every single aspect, the FDA have even declared and made the claim that Baltoco is clinical superiority over Diastat. So have those conversations with them. I think you're in mute.
Sorry. There's a question in the chat from Sarah. She said that pediatric neurologists from Sacred Heart in Spokane are hesitant to prescribe it. Why do you think that is?
So that will be so I will try. That is, I think it's probably is because two reasons. One is they don't respiratory depression could be one. They don't manage all the information. The other one is the pricing. So normally doctors, they have three different, they worry about three things: safety, efficacy, and access, right? So it has to be one of those three areas. Then someone needs to address with them. So what I would recommend is try to connect those. Is child neuro you're saying, or just pediatrics?
Sarah, can you speak to that? Because I only see that you wrote pediatric neurologists in there.
Oh, so it's a pediatric, so it's a child neuro.
Yeah, sorry, child.
So it's a child neurologist. So in that case, what we recommend in those cases is try to connect those physicians with in that case, it will be Jim, the territory manager for Spokane, or like with the medical team of Neurelis. They can educate all the areas and answer the questions about about TOCO. That's what I would recommend. And they need to just take the step. Some doctors are more hesitant with drug medication. They're a little bit like newer than others. They wait more time before they start to prescribe. Some of them, they're more innovators and they start right away. Like they don't wait. But that's what I would try to say. I think there is a bar that they need to just learn and they don't know yet.
Right. Any other questions for Oscar? All right. Well, we really appreciate you being here. Thank you so much for taking the time out of your busy day to be with us. And thank you to all the nurses for taking time out of your busy day to be with us for this time. And we are grateful to have you and grateful to work with you. And if you have any suggestions on topics that you'd like to hear about in future meetings, we'd really love to hear from you. Please send me an email and we'll try to tailor these meetings to what you would like to hear about. So if there aren't any other questions, please go ahead and hang on just 1 second. Let me share this last little slide, especially for those that will be watching this a bit later. This is just information about collecting clock hours. So if you are wanting to purchase clock hours for the professional development and learning, there's instructions on the screen, or you are welcome to email me and I can work with you on that as well. So again, thank you, Oscar, and thank you to, in his contact information, it's in there if you have any questions for him about Valtoco. And thank you to Dr. Wallace and Garth and Kathy for providing more information for us today. So with that, we will let you get back to your students. And see you next month, everyone. Thank you.
Bye.
Bye-bye. Thank you for coming.
Absolutely.